So welcome back, acupuncturists. Now, an introduction for our next speaker feels almost redundant. Mike Cummings is a well-known and respected figure in the field of acupuncture in the UK, acupuncturist, director of the British Acupuncture Accreditation Board, associate editor of acupuncture in Men, medical director of British Medical Acupuncture Society. The list does go on. Now, the focus of his session, Acupuncture, a Biomedical Perspective, will focus on the broad mechanisms underlying the effects of acupuncture, maximizing these effects and avoiding the nocebo. A full biography for Mike and all of this weekend's speakers can be found in the delegate's handbook for the conference. But for now, without any further ado, I welcome Mike Cummings to the British Conference of Acupuncture and Oriental Medicine. Welcome, Mike.
Oh, sorry, just left myself muted. Thank you very much. It's a pleasure to be here. Thank you for the invitation. In fact, it's I last spoke to this meeting in 2012, so that's the numbers reversed, which seems cosmically suitable. I should just point out a correction. I'm on the BAAB, but I'm not the medical director of the BAAB. I'm medical director of the BMAS. Of course, you know that. I'll just start with for those who don't know me so well. I'll start by closing my presentation. Look, I managed to do that. Okay. Can you see that again? Okay. Oh, we have technical issues. I'm sorry about that, but every time I try and advance my slides, I jump out of the presentation.
Okay. I believe if you select slide number 1, Mike, before you go into full screen mode, I believe you're starting with your final slide.
That is my opening slide, but oh, yeah.
So we go to number 1. Perfect.
Well, that's a bit of a rookie error, isn't it? Never happened before. Right, better get on. Thank you again. Thank you for the invitation. Let's talk very briefly. For those of you who don't know my background, I studied Western medicine in the 80s. I was always interested in musculoskeletal medicine, so I rapidly tried to direct my medical career in that direction, mostly sports medicine to start with. I came across acupuncture by accident in the military, would you believe, in the late 80s. And it took me a few more years, though, to get the time. Well, I had to become the boss in order to send myself off on a course. And the Queen paid for the course and the needles. And I did an immense amount of acupuncture in a very short space of time in my last few years in the RAF, a great population to treat. And I threw away my needles and syringes with steroid and local anesthetic in them. And I just really did acupuncture and electroacupuncture. Principally. I did still inject 1 or 2 people, but only after acupuncture had failed. My colleagues dragged me into publishing, and I rapidly, and then I took over education in the BMAS. That was a real challenge. I mean, you have to know stuff to teach it. It's a really good way of learning your stuff is to be put up and said, right, now you need to teach this. You really have to learn it. So I learned a lot by teaching and a lot of anatomy. And I got dragged into publishing by my colleagues, particularly Adrian White and Jackie Filshy, and here are a couple of the textbooks. I also got dragged into getting involved in our journal, which is another huge learning curve in all sorts of ways, having to review papers and edit papers and manage a journal. So that was all unexpected, all of this, frankly. I published my first systematic review now 20 years ago, and at the same time, around the same time, I got the full-time post as medical director, which is my current full-time post. So I've been, for the last 20 years, full-time involved in acupuncture, really. And I've been listening to what's happening in medicine, the bigger world of medicine, when I'm teaching and when people come to watch me. But, luckily for me, I stepped out of the hardest part of medicine, really, which is which is acute medicine in the NHS, which is a tough world to live in. Now, I've published 94 things so far in total, a few more to come on the way. I'm pleased to say that our big textbook, this is probably the landmark, is our big textbook. Must have taken a lot to translate it into Mandarin. Anyway, it came out this year in Mandarin, and I got various messages from colleagues in China after that. I'll come back to that. This is Korean. The Koreans are they're very quick to translate. So this is the second edition of the smaller handbook. They've already translated this one and previous ones. Okay, so that's a bit about me. No, we'll go back to one. I'm now mostly, actually, I write on the BMS blog, which you're all welcome to go and look at. It's freely accessible. It's a research blog. It's a little bit technical in places, but that keeps me busy each week. So I've given you a little introduction. What I'm going to do is I'm going to start with a couple of perspectives, my perspectives, but I think they're useful perspectives on the position of acupuncture in medicine, not the journal, but acupuncture as a whole within modern healthcare, and the position of the Western, I'm going to call it Western medical acupuncture, but what I mean is the biomedical approach within the bigger field of traditional East Asian medicine. I'm using the term that I picked up from colleagues in the BACC, using the term team as opposed to TCM, which is broader. So traditional East Asian medicine, that's what that stands for. Then I'm going to briefly go through the mechanisms with a few new bits. Many of you will have seen this information before, so I'll just pick out some of the newer parts and look at avoiding nocebo briefly and just show you the mechanisms there that come in now that these have been established. A couple of slides on the principles that we use. As you know, we go from mechanisms to treatment, and therefore we need to have principles by which we do that. And a couple of slides on that. And then a nice slide that I drew when I was rather nervously waiting to speak to a very large room full of traditional acupuncturists in China, traditionally trained doctors in China. I was expecting to see Western doctors, but I was put in front of a room of TCM doctors. So I had to try and, in one slide, try and summarize the differences and the perspectives. And then I'm going to show you a few papers, a few recent very large clinical trials coming out of China, which I think are very promising, published in big journals, and using an approach that fits what I'm going to be presenting, fits within both the Western, the biomedical approach, and also the traditional approach, and have been positive and well received. And then I'm just going to finish with one thing. I mean, some of you might comment that, well, this has always been part of traditional practice. I'm going to tell you one thing that, for me anyway, the evidence and the mechanism approach changed my practice and led me to use a new sort of approach, a new technique, directly as a result of evidence. And whilst we may have already been using it in acupuncture, I think the mechanistic evidence does change the process a little bit. It gives us a steer as to how we should best be using this. Okay. So here are the perspectives to start with. Acupuncture, here's acupuncture, and this is Western medical style of acupuncture in there, that little tiny blue one, and the whole of medicine. And this is a bibliographic perspective. This is when I put this slide together last week. This was roughly the number of publications on PubMed, so biomedical database that's based in America, the National Institute of Health in America, their library basically, and the number of acupuncture, the number of citations you get if you just put acup and a wildcard in the search box. So you can see the difference is 3 orders of magnitude. There are 3 zeros different. So you might think, okay, then acupuncture as a whole bibliographically is 1,000th of the whole of healthcare. That actually sounds quite big to me. I was quite surprised. I think we're sort of overrepresenting ourselves, and we're certainly not 1,000th of healthcare in terms of practice. We need to be bigger in terms of practice. We need to get into that big blue circle, and we need to start integrating. And in order to do that, we have to get together. The whole of acupuncture, we all need to get together and start to try and make inroads. So here's the Western style or biomedical perspective there. You can see I've put it almost entirely within team, because actually it is nearly everything we do in the Western approach is just a subset of what has always been done, maybe with different ideas and maybe with different names, but ultimately it's the same. And here's just a few examples. The mechanistic approach, we use 3 terms, local, segmental, and general, as the overarching description of mechanisms. And, local needling is, of course, very common in the traditional approach. And so that has both local and segmental effects in terms of its mechanisms on pain and other conditions. Distal points, I don't use the term distal anymore, but it's the one I first heard, the combination I first heard was local and distal. So lots of distal points are actually segmental for the conditions that they're used for, although not all. And then, of course, back shu and front mu points, they're often segmental for the relevant organs or conditions that are being treated. Now, I've left a little bit of the ellipse, the blue ellipse there, just hanging out, because there are some new things that have been brought in with the modern approach. And then, of course, there's all of these aspects of dry needling. In fact, we had a presentation, I was organizing one of our scientific meetings yesterday. We had a presentation from Cesar Fernandez de la Peñas, a name maybe you don't know, but you should. He's not famous in the world of acupuncture, but what he does is the same. And he calls it dry needling, but he is the most prolific researcher and writer in this field. And I checked yesterday, and he's published, I should say first, he's about 15 years younger than me or more, and he has published 529 papers on PubMed as of yesterday, and they just keep coming out week on week. He's, super prolific, a very bright guy, and it's a very, very interesting stuff that he's doing in that field. Certainly worth looking at. Okay, so a little bit, I don't know whether that hangs out, or a lot of what they do is very similar, but there are some newer techniques that don't fit completely with the traditional approaches. Here's a good friend and mentor of mine, Thomas Lundeberg. He was very much influential in the rise of acupuncture research in Sweden, and Sweden, under one of his senior colleagues, was one of the places that acupuncture really was put on the map in terms of modern orthodox healthcare and Western trained doctors sort of taking notice. And so some of the research that was done there in their labs was important there. And so Thomas has a great understanding of mechanisms, sensory mechanisms, and he's a great cartoonist. So I'm borrowing his diagrams. I've just copied them. And this is a summary diagram for the mechanisms of acupuncture. And obviously it's simplified, but we don't need to go into all the very intense detail. And I'm just going to give you an overview of these mechanisms. My favorite approach, if I can do it, is to go local, and that's because local needling to conditions gets all of the mechanisms. It gets your local mechanisms, it gets segmental modulation, and it gets general effects potentially. So you've got 3 different sort of areas of effect. And we know that there are these various local effects that occur particularly in muscle tissue, and it's in a 3-dimensional range. You see on the skin, you see flare in the skin, a red flare in some patients, bigger than others. But in nearly all patients, you will see, whether you see a flare in the skin or not, you will see increased blood flow in a larger area around where the needle tip is, stimulating nerves in deep tissue. More recently, the role of adenosine has come in, and maybe 10 years ago, it first shocked us that adenosine was an important part of effects, at least those effects measured in the laboratory. in practice, I'm not sure this is so often relevant, but sometimes it may be. But certainly in laboratory mechanisms, adenosine seems to play a role in certain types of animal models when in terms of antinociception. So blocking the signals that eventually will end up in a pain perception. And then what Cesar does a lot is to look at trigger points. Cesar I mentioned before, and there's some research to suggest now that in fact the microscopic damage performed by certain acupuncture techniques is part of the mechanism of treating some types of muscle pain. Here are a few of the neurotransmitters. Here, NGF, CGRP, SP, and others. There are many others. It's a complex soup that you're manipulating when you put a needle into tissues there and stimulate it. And we know from Helen Langevin's work about the interesting effects that can happen on fibroblasts, and they release adenosine and all of these other things that occur, nitrous oxide and the like. Here are the different fibers involved. These are our own way of defining different types of sensory fibers. That's not so important. But I'll move on to the segmental side of things. So this is a long loop in humans. I used to think it was all going on at the spinal cord, but in fact, most of it seems to be a long loop. This is in the brainstem now. This is where beta endorphin has most of its effects, and you have these descending inhibitory systems. Now, this is critical, I think, in a lot of chronic pain circumstances. It's in chronic pain, you have a change in the spinal cord. There are like these little amplifiers that get turned up. And acupuncture is a great way in most people of turning them down. But you have to repeat the treatment. You have to repeat it strong enough and long enough to do that. And you'll have all seen this in your patients. Eventually, you turn the pain right down. It might even go off completely, and it stays off for weeks, potentially, after a course of acupuncture. Acupuncture doesn't work for weeks. That's an important thing to grasp from a physiological perspective. The effect of acupuncture is no more than 2 days in physiological terms. But the result is the patient is back to a more normal place, and they stay there for a length of time because it takes time for those amplifiers to wind up again. And that's probably the reason why we see effects that can last for weeks and months in patients particularly with pain symptoms and other things. We also have a segmental autonomic modulation that goes on. This isn't just one segment, I should say. It's pretty much, I usually say about 5 segments. You can measure the effect at 5 segments. The principal effect is in the one stimulated and the ones either side. But up to 5 segments, you can actually, at least in experiments, you can measure changes in the spinal cord. Oh, I should go back. Target-directed expectation. Yeah, this is, if you like, a placebo. You can engage enhanced placebo effects by pointing to an area. And this was established by Benedetti over 20 years ago. It's a real pain for acupuncture because even the non-penetrating needles are a great way of engaging this target-directed expectation. So when we all know sham acupuncture works better than many treatments we use in conventional care, it seems from the research. Now, this is heterosegmental effects are effects at other ends of the segment. And I'm adding this in. We used to always include this slide, and then I took it out because it confused people. But it's really the same as what you've just looked at. But these effects, the descending effects, aren't always consistent. The powerful effects are just in the segments that you stimulate. Those are the most powerful. But there are other techniques, and you'll have come across techniques, very strong techniques that you use at a long way away from the problem. One example is stomach 38, needling stomach 38. So I've had this done by Jorge Vaz after his publication some years ago, 2008, and he used a single needle to treat chronic shoulder pain. But he didn't use it on its own. He used it in exactly the way that is logical, both in biomedical terms and true to the historical perspective. He took a long needle and inserted it through stomach 38 in my leg, right the way through to the back, and then gently twisted it. It didn't hurt, but it was a strong sensation. And I could feel it through 3 compartments in my leg. And at the same time, so what he did in the trial was he gently twisted that needle and got the patients to mobilize their bad shoulder. That's the technique. Now, this uses a particular type of neuromodulation, which is different from the one we normally use in acupuncture. In acupuncture, we're normally using segmental approaches. But this is using a technique where the very strong stimulation tends to focus attention where it is and blank out inputs from elsewhere. So it typically works when it's a long way away from the condition. And what the pain physiologists call this is, that they used to call it, originally it was called DENIC. And I was always annoyed because they used to say, oh, acupuncture is just DENIC. But it's not. Acupuncture isn't noxious. Both of these terms, the modern term is heterotopic noxious conditioning stimulation. But you can see both of them have got noxious in there. That's not right, because acupuncture isn't noxious most of the time. I mean, it can be, but if it's done correctly and well, it can be a strong sensation, but it's specifically not noxious. So this doesn't fit for acupuncture. So it always annoys me when people dismiss it and say, oh, it's DENIC. It isn't DENIC, but there are some acupuncture techniques that utilize this, but they don't need to do it in a noxious way. So the reason noxious is in there is because these researchers always stimulate the skin. And if you use high threshold techniques on the skin, it's going to be noxious. But if you use high threshold techniques under the skin, which is what acupuncture is, it isn't noxious necessarily. That's enough of that. What about the overall effects on the brain? Of course, there's lots and lots of research on this now. In the last 15, 20 years, I lost track of the number of fMRI papers, and they just keep coming out. And there's some fascinating changes. We've seen changes in the way that in patients with pain, for like carpal tunnel syndrome, for example, we see remapping of the cortex. We see changes in the white matter, which is fascinating, and see differences in electroacupuncture stimulation in one limb compared to another, and actually measure changes in the brains of the patients. That's fascinating. That was, of course, Vitaly Napido's work from Harvard. In general, though, if I summarize it, generally you basically get the limbic system turned down. The limbic system is where we suffer. It's also where we have fun and where we love and we have feelings for people, etc., etc. But in general, acupuncture tends to settle everything down, put everything into a default mode, which is a nice sort of relaxed, daydreamy mode, if I could summarize it like that, and had less effect on intensity of pain sometimes. So the patient might still rate their pain quite high in terms of intensity, but they don't care as much about it. So that's quite important when you're a researcher measuring changes in pain, that you make sure you do measure the bothersomeness of pain, not just the intensity. So yeah, that's everything. Expectation and conditioning, of course, that's in there, and there's elements to which the target directed expectation comes into there. And the new thing, which I'm going to talk about, which is these anti-inflammatory reflexes, which can be very strongly, powerfully engaged by acupuncture techniques. So central autonomic modulation, principally through the vagus. And these are very exciting, I think, although unfortunately not well researched at the moment. Nobody's very interested in using acupuncture when they could be using something more expensive. Sorry, I shouldn't say that. Now, where are we? Avoiding nocebo. So this, for you in practice, this, I think, from looking at the mechanisms and from studying this for years, I think this is the most important. We have to make sure our patients aren't anxious. And there's all sorts of ways in which we can do this, and there's all sorts of input, but this is critical. You need to engage with your patient. You need to look at them. You need to touch them in a carefully, the way you need to interact with them carefully. You need to pay attention to your body language, your tone, the environment in which you work. All of those things can either increase or decrease anxiety, and it's really important. And when you first treat a patient, obviously you want to be careful about that, because you don't know what's going on in their head necessarily, and they may not tell you, especially if you're a young ex-military guy with no hair leaning over them and you're twice their size. You know, you need to get used to that, and it took a few years for me to get used to that idea. And now I consult my patients sitting on the chair. I keep myself small, and I smile a lot and look at them. So this effect, so if your patient is anxious, their brain will release CCK8, which opposes endorphins and enkephalins, directly anti-opiate. So, you know, if you've got an anxious patient in about to have surgery, you have to give them more opiates. They need more drug to counteract this, just for anxiety. It's not, you know, this whole business of the Cartesian split. That's rubbish, of course. There's no Cartesian split. Mind is body. Mind is part of body. it's not all in the mind. There's nothing that's all in the mind. If it's in the mind, it's in the brain and in the nervous system. Okay. So that's that. What about our principles? Quickly, this is an old picture of me some years ago. So with Adrian, I took over Adrian's practice. It was a bit of a surprise, and I got dragged into research. But we had to sit down one day and say, look, if we're gonna try and formalize what we do, then we need a system. And so we came up with this relatively simple system of overlapping. Everyone hated it for years, but now they've got used to it, of what we look for locally and what we look for at a distance. See, distal has changed to distant, and that's because some of our segmental approaches are proximal rather than distant. So that's a subtle change there. I never liked this whole mishmash. There was no real logic to this. They were just adding other things that we sometimes use. This is a more modern approach that I produce, but I don't use in teaching because it's too complicated. But this is probably now a more accurate sort of summary of what I would do today from the biomedical approach. And I won't go through and explain that now, or I'll run out of time. Here's the lovely little diagram I drew. I was very proud of this for a while. I drew for the Chinese doctors to try and explain what I was doing, and try and set up the discussion of mechanisms. So here, as I've already alluded to, the importance of communication, and that not just speaking, but also body language, tone, and the environment in which you are treating the patient. But and of course we think different things. The patient has these different things going on in their own head, and we, depending on whether we use a biomedical approach or a traditional approach, we have different things going on in our heads. But ultimately we all end up doing this, and the mechanisms are the same. So it's really important, no matter what approach you use here, that as a whole, when we're researching acupuncture, we engage with these. And what I'm going to show you now is probably an example of the fact that this is now happening, and I'm very pleased to see that. What advantages is WMA? Well, sometimes it reduces complexity. Sometimes the traditional approach can be quite complex, and so for some patients, you can just run straight in there and use quite a simple approach and get good results. This is particularly with peripheral types of pain. Of course, it's useful in terms of a language. Learning this stuff is really useful if you're going to engage with rather skeptical, orthodox healthcare professionals. I mean, they're reducing, but we've still got a lot of skepticism. We've got a long way to go. I think we've got to combat capitalism more than the skeptical orthodoxy. But there we go. And very importantly, I think this is really important. We've spent years making mistakes, and unfortunately, we're still living with those. The big sham-controlled trials in back pain, for example, the 2 big sham-controlled trials in back pain are the reason we no longer have acupuncture recommended in the UK for back pain. And it's not because it doesn't work. It's because the sham was so good. Sham outperformed conventional medicine, but because the difference between real and sham was so small and the trials are so big, it's holding down the results in meta-analysis, and it's going to be difficult to overcome that. So we really have to be careful how we do our big trials. So here's just a few examples. This knocked me over when I saw this trial. This is the biggest ever sham-controlled trial of acupuncture, and this is probably one of the first Chinese sham-controlled trials, because in China they didn't used to do sham-controlled trials. They just compared acupuncture with alternative, with conventional medicine, often with drugs and stuff, and very useful papers. But unfortunately, because they're open, they have high levels of bias associated with them, and therefore they don't get rated. And then lots of other potential problems as well. But this was the first one, over 500 in each arm. This is the huge. This is in chronic severe functional constipation. And just to show you briefly, this is the protocol they used. So a very tight, strong stimulus, segmental. I mean, I thought, this is fabulous. And of course it showed, and the difference was significant because it was so huge, the huge numbers, they got significance, but it wasn't massive. There weren't, it wasn't like super brilliant effects, but they were, so it's believable, absolutely believable. Fabulous study. Here's another one on stress incontinence using another very tight protocol. As you can see here, electroacupuncture. And this was the first one I saw using non-penetrating needles as the sham with no electricity. So this is really good. if you think the physiological stimulus is important, this is the type of thing you want to do. Strong electrical stimulation compared to no electrical stimulation and no needle penetration. And this was another positive trial published in JAMA in 2017. And this one very much more recently in chronic prostatitis. This one used manual acupuncture. Again, a big trial, 220 in each arm of the trial. And here are the points they used. You'll be familiar with all these points. You may not be so familiar with the techniques they used in these ones. They did use quite long needles in bladder 33 and 35. So 33 goes into the S3 foramina. So they are needling into the foramina. That's very difficult to do. You know, you need practice to do that. And then just at either side of the coccyx, they're needling up and out quite deep. So they're going to get close to the pudendal nerve or the pelvic floor muscles there. In that point, and those are the same points they used in that previous study on stress incontinence. So I think what they were doing was direct stimulation of the pelvic floor. These are techniques that, you know, are not so common here, but again, a good result and a really good trial. So that's great. I'll just finish. I've got 1 minute left on my clock here. I'll just finish with the future innovation that I think came out of mechanistic research, and this was it's a nearly 20 years ago now that Kevin Tracy first described this reflex in the journal Nature. It's a big journal. But it wasn't until later that I took notice of this. And it wasn't actually until 2014 when this paper by Luis Aloa's group from the States, he's Rutgers University at the time, he's moved to Duke University. And he studies inflammation. And he just he met this guy, in fact, in Mexico, and the guy said, why are you trying to dissect the vagus in small rodents? Why don't you just do acupuncture? It's much easier. So he just put it through the lab and tried it, and sure enough, it worked in a septic shock model. You can see some interesting effects after I invited him over and started discussing the intricacies of electrical stimulation and what acupuncture and electroacupuncture is. And it was a surprise to me to then get an invite from GSK. I didn't end up going to advise them. You might be interested to hear. I wanted to know what they were doing, but the BMAS didn't want me to go. And I obviously didn't want to be paid because that would be a conflict of interest for government purposes. Or nice purposes. So this is an approach now that I use. This is the type of approach, electrical stimulation around stomach 36 is what has been used in rodents a lot, and it strongly engages the anti-inflammatory effects. And this has been studied in detail. And I've been using this, thanks to this patient here, I've been using this technique for some years now. And for a couple of years before I saw the research, and now I specifically engage this technique in trying to prevent inflammation. So we can't treat acute inflammation well with acupuncture. I mean, there are effects, but they're not good enough when we need to really stop inflammation. We need strong drugs, steroids, et cetera, et cetera. But you can prevent it by regular treatment. And of course, we know this traditionally, but we didn't know the parameters. You need to do this 2 or 3 times a week. The effect lasts 48 hours, maybe 72, but definitely 48 hours. So in order to be properly preventive, you need to be doing constant treatment 2 or 3 times a week. And I've done this now. I teach patients to do it. And I've got patients with rheumatoid arthritis in remission for years using this simple technique. So in summary, I've told you about me. I've given you some perspectives. I like this perspective. What I do is a subset of what you all do, and we're all in here somewhere. We need to get together and get acupuncture more involved within orthodox healthcare. I hope I've convinced you that you need to engage these biomedical aspects when you're planning trials, and we need to try and make sure that people running trials, and I think it's been successful, that influence has had an influence, looking at these big trials coming out recently from China, and that's great. And and I'll wait and see. This is growing as more and more, we discover more and more. This bubble gets a bit bigger and takes in a little bit more of those techniques that have always been performed in traditional approaches, but we don't quite understand yet. I don't think it'll fully embrace the whole. There'll be some things that we want to probably leave out, some things that are perhaps too dangerous. Anyway, I'll leave it there. Thank you very much for listening, and I shall now stop sharing. How was that? I'm a little bit over time.
Fantastic. You are one of our favorites for keeping to time so splendidly.
Oh,
Now we do have a couple of questions which are accumulating in the chat box. Do you have access to this, Mike, or would you like me to read these out to you?
I do. I haven't been looking at it. It's always difficult when you're lecturing to look at chat boxes.
Absolutely, right.
Seems to me that Western a language. So yes, Pia's talking about the language problem. Yes, absolutely. And one of our problems is we have to go to them. We have to go to them. We can't expect them to come to us, especially when it comes to language. We have to learn the language of the people that we need to talk to. And that's why I'm learning Portuguese and Mandarin, and have done for the last few years. No, because I'm always going over there lecturing and feeling guilty that I speak English all the time. But in terms of the traditional approach and the orthodox approach, we need to approach. I always, speaking to a new professor, I'm always going to be bigging up the mechanisms, depending on what sort of professor they are, rather than the more ethereal philosophical concepts, some of which are really interesting and should be researched, but you want to go in first line with the hard, what looks like hard science, I think. And there's plenty of it now, I think. Jennifer, do you have any any
book recommendations?
Which?
Any book recommendations?
Oh, they're book. Is that a short? I have to do that for book recommendations for further reading. What, in the biomedical approach? I would be, well, slight conflict of interest. That's one of the reasons we wrote the introduction book. The introduction book actually has gone around the world, and I was surprised, actually. If you want to be famous around the world, you write a book. You don't publish papers. Nobody's read my systematic reviews. I've published loads of systematic reviews. Nobody's read them. They've read the book. Yeah, so if you want to become famous around the world, write a book. It doesn't have to be long. I went to Australia a few years ago, and I was really surprised to find, I always think nobody's going to know me. And I sit there, and I was about to leave to get my plane home, and there was a string of about 50 people with books in their hands, all wanting the inside cover signed. I hadn't known, but they had adopted it as a standard text. Same, they adopted it as a standard text in Brazil. And then they complained to me that they'd brought out a new edition. We'd brought out a new edition, and it hadn't been translated into Portuguese. And they couldn't get hold of the old one that had been. So there we go. So that's any other book recommendations? Well, books, let me say, as from an academic perspective, I don't read books. I listen to books. I listen to philosophy books, and I can recommend, oh yes, a really good one, actually, not to do with acupuncture. Jeremy Lent, Cognitive History of Mankind. What's it called? Patterns. Does anyone read that one? Jeremy Lent, it's a fabulous book. But yeah, I can give you all sorts of other recommendations for great books, but they're not to do with acupuncture. But understanding human evolution, how we came onto this earth. Jeremy Lent was the one who told me that actually the genetic diversity in Africa is 10 times the genetic diversity in humans across the globe. And that suddenly gives you a very different perspective on your position and, white male supremacy, for example, in history. That's, actually the vast majority of humans are in Africa, and the vast majority of diversity in Africa. And we are just one little group that happened to walk out across the Red Sea when you could walk across. I think they walked across from the Horn of Africa. In fact, apparently you could walk across in those days, several million years ago. Right, better get on. Best papers, physiological. High versus low AP responders. How many translate responder state? No, responder status is, when they brought out enrolled enrichment in pain trials, that's what the drug industry do. They find out who responds to their drugs before they randomize. It's in some of these so-called enrolled enrichment trials. I thought about that, whether we should do that for acupuncture, and I'm not so sure we should now, partly because the good responders respond to sham really well as well. And you've got a problem then if you're doing a sham control trial. I quite like the superficial shams. I like the needling shams if you have to do them. if you have to do them. I prefer strong electro versus a very gentle, superficial, non-electro sham. I think that gives us the biggest difference, partly because these non-penetrating devices make the acupuncture worse. They bring down the effect of acupuncture in the real group, and that's been measured now, dramatically down. And so I would rather have a sham that's a bit better and then do a really strong technique. But then you have to choose your patient population. And I don't think we want the good responders, because they're going to be really difficult. They're going to respond to very gentle techniques sometimes. And I don't think we've fully evaluated that. So I'm not sure that approach of enriched enrollment would work for acupuncture. In terms of where to get information about high versus low physiological responses, if you have a look on our website under hot topics, it's not exactly very hot, frankly, because I don't update it very often, but it's called Hot Topics, and it's a pain to change the name of the page. But there's a summary research paper document with like 100 references in it. On the first page, there's the most recent one that looks at mechanisms by Joe, I think, Zhao. It's lead author's Zhao, Progress in Neurobiology. It's quite old now, but a fabulous in-depth discussion of mechanisms based on basic science. That's certainly worth dipping into and referring to. Inflammation prevention using SD36. Do you give needles to patients to treat themselves 3 pints per week? Yes, so I do two things. I teach, it's a nice, safe place to teach patients. We've got videos for patients on our website, so that if we've taught them a few simple points, which we do in the NHS, quite a lot. Stomach 36 is one of my favorites for teaching patients, and then they can wiggle their toes a little bit if they want to manually stimulate. And I get them to do it at least twice a week. Those who can afford it, I get them to get an electroacupuncture machine and then put a pair in each side, with my favorite other one, which is called Zongping. I invented that point before I realized it had already been invented, because I wanted one close to stomach 36, and the next one was further down. I thought, oh, I want to go closer, because I wanted my electricity I wanted to control where it was going. And so it was quite funny to then find a paper which talked about Zongping, and it was the only point I've ever invented.
And thanks so much for everything you've given us today, Mike. We're going to have to wrap up for our break session now.
Okay.
I do feel terrible about cutting you short there.
It's fine.
I'm sure we could all be prying your consciousness for all sorts of interesting information. I'll just wrap up the morning session now, and we'll run into our breakout rooms. I do encourage everybody to visit the virtual stands for Suwen Herbs and for the Northern College of Acupuncture. We'll be reconvening at 11:25, and Ian Appleyard will be taking over the chairing for the rest of the morning. I hope you all have a great conference for the rest of the day until we reconvene at 11:25. Take care, everybody.